Welcome to the webinar, Breaking Down the Barriers to PCSK9 Inhibitor Use in Clinically Appropriate Patients, bringing payers and providers together to enhance outcomes and access. This program is provided by North American Center for Continuing Medical Education, LLC. This webinar is supported by an educational grant from Amgen, Incorporated. I'm Dr. Eric Cannon. I'm from Select Health in Salt Lake City, Utah, and also presenting with me today is Dr. Michael Block from the University of Nevada School of Medicine in Reno. We will be your presenters today. On this slide, you can see our disclosures. Looking at the learning objectives for today, what we'd like to do is review the latest clinical trial data around the PCSK9 inhibitors. We want to assess the current evidence around what is the optimal LDL-C goal for our patients. We want to be able to identify the appropriate patients for PCSK9 inhibitor therapy. And then we also want to make sure that we address payer and provider-related barriers to appropriate evidence-based use of PCSK9 inhibitors. So to that end, let's take a look real quick at the epidemiology of cardiovascular disease. I think we all learned about cardiovascular disease in school, but I think looking at these numbers reinforces the magnitude of the problem that we're faced with. Cardiovascular disease is the leading cause of death, disability, and medical costs in the United States. It's a disease that impacts 1 in 3 Americans. The annual direct and indirect costs are between $400 billion and $600 billion. And the American Heart Association estimates that by 2030, almost 41% of the U.S. population will have some form of cardiovascular disease. The number that's very staggering to me is this idea that between 2010 and 2030, direct medical costs for cardiovascular disease are projected to triple. So let's break the numbers down just a little bit more. Coronary artery disease, we know it affects about 15.4 million adults, and it's associated with $126 billion of annual direct medical costs. Peripheral artery disease, a little bit smaller number, 8.5 million adults with $21 billion in annual direct medical costs. Stroke, 7 million adults, $19 billion in direct medical costs. Looking at it a little bit differently now for acute coronary syndrome, acute coronary syndrome accounts for almost 900,000 annual discharges from the hospital. And it's responsible for $75 billion in annual direct medical costs. In this trial, Nichols and colleagues, they looked at 12,000 patients that had been entered into the Kaiser Northwest Cardiovascular Disease Registry, and they were looking between 2000 and 2005. And I think so we know these numbers are a little bit old, but I think they give you a sense of what we're talking about. On average, total costs for cardiovascular disease were $18,900, almost $19,000. Of that, $3,400 were pharmaceuticals, just over $8,100 were for inpatient use, and outpatient costs were about $7,400. So I think one of the things we do know is that as we continue to push newer and newer pharmaceuticals, we will probably see that $3,400 number increase. For all of us within the health plan environment, we're all familiar now with the Medicare Part D measure for patients with diabetes needing to be on a statin. And I think this portion of Nichols' study reinforces why that's important. If we look at patients that had diabetes and cardiovascular disease, their average annual costs were $27,000 versus those patients without diabetes had annual costs of just over $17,000. We had talked about the projections of the American Heart Association. I think this slide does a good job putting that into perspective for us, where by 2030, it's anticipated we will see a 198% increase in cardiovascular disease and a 238% increase in stroke. And then one slide that I'd like to focus on a little bit before I turn the time over to Dr. Block is looking at this idea of statin adherence. And I think one of the things that will be critically important for us as we manage our patients and lower their total LDL, we need to make sure they're adherent to therapy. What they did was a meta-analysis of 20 studies. They came away from this with the primary conclusion that statin adherence is poor. Only 57% of patients were adherent in the primary prevention group. The secondary prevention group, the patients are a little bit more motivated, so 76% were adherent. But over time, statin use decreased. And after 5 years, we're looking at only 26% of patients that are considered adherent to therapy. So I think as we look at treatments, that we look at improving outcomes for our patients, this idea of adherence is going to be critically important. With that, I will now turn the presentation over to Dr. Block.
Thank you very much, Dr. Cannon. I will now discuss the current landscape regarding lipid management and really focus on how PCSK9 inhibitors fit into our current treatment paradigm. As I am sure you're all aware, the landscape of treating lipids really took a dramatic change in 2013 with the publication of our newest guidelines from the ACC/AHA, which really called for 4 groups of people where we should be really considering statin therapy. Those 4 are shown on this slide: patients with clinical atherosclerotic cardiovascular disease, those who have a baseline LDL-C greater than 190, most of our diabetics who are aged 40 to 75, and in primary prevention, those who have a greater than 7.5% calculated risk of ASCVD who are between 40 and age 75. All of those patients in those 4 clinical groups qualify for either moderate or high intensity statin therapy. So that is really the paradigm we've been treating under since 2013, which actually from cardiovascular standards is quite some time ago. And I would argue that we have had a lot of new information and also a lot of new tools available to us since 2013. And as we go through this slide set, I'll be highlighting some of the changes I think that have occurred in our paradigm of treating lipids, including some of the latest updates to these guidelines from the ACC. So I think that really leads to the question of why we need to discuss non-statin treatments at all. And I think that the guidelines have done a great job of showing us that statin therapy is the baseline of therapy in patients who have dyslipidemia. But there are individuals where we might have a clinical need to further lower LDL cholesterol levels. And those are shown on this slide. And I'm going to go through each of these in some detail. The first are those individuals who are unable to tolerate moderate or high intensity statins. We also have patients who have genetic disorders in lipid metabolism, specifically familial hypercholesterolemia. And then also there are patients who have established atherosclerotic cardiovascular disease who have a persistently elevated either LDL cholesterol or non-HDL cholesterol despite maximally tolerated statin therapy, of course, with good adherence. So in each of these patient groups, we think that there is a need to identify and lower residual risk. So I said I'll go through each of those in turn. First, speaking about statin intolerance, and this has been, probably our most vexing problem in the treatment of lipids is that at least perceived intolerance to statin therapy. And clinically, this is an incredibly difficult diagnosis to make. And I think until we have a better biomarker for people who are truly intolerant of these drugs, it really is a matter of clinical decision making. And what you see on this slide is a scoring system that's been proposed by the National Lipid Association. Personally, I don't formally use this scoring system in my office, but I do think the concepts that are shown here are very sound, and they really highlight the patient who is likely to truly have statin-induced myalgias as opposed to myalgias for another reason. So patients who have statin-induced myalgias definitely tend to have symmetric pain in the big muscles of the body, mostly the hip flexors and the thighs. Usually, but certainly not always, but usually the symptom onset is within about 4 weeks of starting a statin. Importantly, if it's really statin-induced myalgias, it should improve upon withdrawal of the drug, usually within 2 weeks, and also should recur with a re-challenge with a statin. So that de-challenge and re-challenge, I think, is critically important in making this difficult diagnosis. So once we have a patient that we think may be statin intolerant, and I think, once again, the onus is really on us to prove that a patient can't truly tolerate these drugs. What do we do? And there's a lot of different maneuvers that can be taken to try and treat these individuals. I think the most important thing is to really remind the patient and remind our fellow providers that whenever possible, lowering LDL cholesterol with statins is our primary target to reduce the risk of coronary heart disease. So everything possible should be done to get a patient to tolerate as much statin as they can. So first thing, of course, is to make sure a patient doesn't have an elevated CK, which would be indicative of a myositis or even rhabdo if it's really elevated. But in a patient who has myalgias and a normal CK who is on a statin, first order of business is usually that trial of discontinuation for a few weeks and then a re-challenge to see if the symptoms disappear and then reappear when re-challenged with a statin. Trying a lower dose can be very effective. It does appear that the side effects of statins in regards to myalgias are dose dependent. Important to try a different statin, perhaps one with a different metabolism or different hydrophilicity. We can try alternate day or weekly dosing. Of course, this is off-label, but many of us have done this with some success. And then it's important to look for other potential contributing causes, hypothyroidism being a common cause of myalgias with statins. So identifying that and treating it. There's some data, and some of us have some clinical experience with supplementing vitamin D that may be helpful. Perhaps with a little bit of weaker data, perhaps trying free ubiquinone or CoQ10. But importantly, determining the maximum tolerated dose of a statin, and whenever possible, keeping a patient on at least some statin to offer them that protection, and only then do we consider non-statin therapy, either as monotherapy if we can't get a patient to tolerate a statin at all, or as combination with whatever the maximum dose of statin that they can tolerate. So certainly the patient who doesn't tolerate moderate or high intensity statins is one group of individuals that we might want to be looking at non-statin medications. An important second group, though, are people who have genetic disorders in lipid metabolism, specifically familial hypercholesterolemia, which is a under-recognized but clinically recognizable disorder. It is probably the most common inheritable autosomal dominant disorder that's associated with morbidity and mortality in humans. And different studies have shown different prevalence, but it's probably somewhere around 1 in 250 individuals in the population are affected. It is caused by a mutation, usually in the LDL receptor gene, although sometimes it can be a mutation in a related gene like the gene for ApoB or the gene for PCSK9. And importantly, having one bad copy of the LDL receptor gene, having heterozygous familial hypercholesterolemia, leads to very significantly elevated cholesterol abnormalities, and that elevated LDL cholesterol begins very early in life. And we can see in some of our historical series of patients with FH that especially in men, we can see coronary disease presenting in their 40s. And if we actually look at autopsy studies, we can see that even in children and adolescents, we can see changes of atherosclerosis in the wall of the blood vessel. So I always like to remind audiences that FH is a hereditary disorder, and the first order of business and the first thing I think about when I diagnose a patient with FH is screening the family. Cascade screening is very important. When we identify an index case of FH, we want to make sure that all of that patient's first-degree relatives get tested for high cholesterol, because on average 50% of their first-degree relatives will also have FH. And then if we see another index case based on that cascade screening, all of their first-degree relatives need to be screened, and so on. So from a population health standpoint, that's incredibly important. And I think this slide here really, I think, visually shows the impact of having FH and the impact on atherosclerosis very early in life. This is from an observational study that compares in both men on the left side of the slide and women on the right side of the slide, the incidence of coronary artery disease, in this case it's actually fatal MI, in patients who have FH versus those who don't have FH. And as you can see, a dramatic increase. And that increase really happens quite early in life. And so getting these patients on aggressive lipid-lowering therapy really is incredibly important, and we need to be identifying these patients when they are as young as possible. So identification of the patient with FH, there are a number of different diagnostic strategies that have been published. Personally, I tend to use this one in my practice, which is based on a publication that was called The Agenda for FH. And the diagnosis of FH, really needs to be made clinically. And according to this document and other writing, we really should be suspecting FH, and in fact, presuming a patient has FH if they have elevated LDL cholesterol, usually greater than 190 in adults, with one of the following: either a personal history of atherosclerotic cardiovascular disease, a family history of very high LDL cholesterol, over 190 at baseline, a family history of premature atherosclerotic cardiovascular disease, or a patient who has positive genetic testing. And there are about 1,600 different genetic variants that have been identified that lead to FH, and that's probably only about 50% or so of the actual number of abnormalities. So because of that, we really don't rely on genetic testing usually to make the diagnosis. Most often we're making the diagnosis based on clinical criteria alone. And of course, the third group of patients that we may want to consider more aggressive therapy than just statin alone are in patients who have established atherosclerotic cardiovascular disease, who have residual cardiovascular risk. And I really like this slide as a visual. I think it shows the benefits of early treatment and also shows why it is that when we identify patients too late in the process of atherosclerosis, when they've already had a clinical cardiovascular event, we need to treat them even more aggressively. So if you look at the left slide, down in the left corner of this slide, what we see is that if we identify a patient who is at high atherosclerotic cardiovascular risk, who may just have fatty streaks and those first changes of atherosclerosis, if we put them on moderate to high intensity statin therapy when they're young, they're in their 40s or early 50s, before they've had the development of more advanced plaque, we can really shift the curve dramatically in terms of their cardiovascular risk and really push their clinical event horizon very far into the future. But this is in contradistinction to what happens when we identify patients only late. When we identify patients who already have complex atherosclerosis or have already had a cardiovascular event, which is shown sort of in the middle of the slide at the top of the red bar. When we identify those patients, putting them on moderate to high intensity statin therapy doesn't bend the curve as far, and these patients still have considerable residual risk. And we are hopeful that that risk is also modifiable. So by adding other therapy, we can reduce some of that residual risk and push off their next event further into the future. So I think that concept is a really sound one. In patients who have established atherosclerotic cardiovascular disease, they do have residual risk even once they're treated with moderate or high intensity statins. And we know that in patients who have established atherosclerotic cardiovascular disease, patients who have a higher achieved LDL have greater residual risk. What you see on this slide is a meta-analysis of a number of different studies that shows that the lower the achieved LDL cholesterol, the less residual risk there appears to be. And as you see very well on this slide, that is true even in patients who have an LDL-C less than 100, even true in patients who have an LDL-C less than 70, and suggested even with an LDL-C less than 50. And now we have very good data, I think, that has come out since the time of our 2013 ACC-AHA guidelines that treating that residual risk can be effective in reducing cardiovascular events. Probably the first study that really, at least in the field of lipids, that really proved that concept was the IMPROVE-IT study. So the IMPROVE-IT study was a study of over 18,000 patients who had a known acute coronary syndrome who were randomized to either simvastatin alone or the combination of simvastatin and ezetimibe. And as you see on the left side of this slide, the group that was on simvastatin alone achieved a mean LDL-C of around 70, but in patients who were on simvastatin plus ezetimibe, you saw an additional about 15 to 20% reduction in LDL-C, getting to an LDL cholesterol achieved on average of just below 55. And as you see on the right side of this slide, that additional reduction in LDL-C over and above moderate intensity statin therapy led to a further reduction in risk. So I think this was really our first large-scale study that showed that even in patients who have a low average LDL-C, we can treat that residual risk and decrease residual risk by treating their LDL cholesterol more aggressively. So based on this data, I think we really have this question as to what should our target LDL cholesterol be. As I mentioned at the beginning of my remarks, the 2013 ACC-AHA guidelines didn't really call for us to look at a goal LDL-C. But I think many other organizations have suggested that we probably should have a target for patients with established atherosclerotic cardiovascular disease. And even I think, as I'll show you in a moment, the ACC update to their guidelines are even allowing us to look at some of these targets. That really begs the question as to what should the target be in a patient with established atherosclerotic cardiovascular disease. The National Lipid Association has suggested that perhaps that target should be less than 70. Other organizations, particularly the American Association of Clinical Endocrinologists, have looked at the IMPROVE-IT data and said maybe that LDL cholesterol goal should be 55 or below that. And then I think there is some data to suggest that maybe the LDL goal should be even lower, and that data, as I'm going to show you, has generally been generated from trials with PCSK9 inhibitors. And so I think this is a matter of continued debate, and we are moving towards, I think, more consensus. I am concerned, though, that perhaps LDL-C shouldn't really be the target that we're looking at. I know it's the target that most of us talk about. But if you look at untreated patients, non-HDL cholesterol, LDL particle number, ApoB are all better predictors of risk than LDL cholesterol. And so perhaps we need to be including, this is just my opinion, need to be including those numbers as part of our target of some of the residual risk, particularly in patients with established atherosclerotic cardiovascular disease. So I think that looking at those three patient groups really sets the table to look more closely at PCSK9 inhibitors and where they fit into our treatment paradigm. I just want to take a few moments just to review the mechanism of action of PCSK9 inhibitors. So I think it's a very interesting physiology. And I think it's well shown that the importance of PCSK9 to regulating LDL receptor activity is shown nicely in this slide. When a cell finds that it needs to bring cholesterol in, particularly a liver cell, the way that it brings cholesterol into the cell is by making more LDL receptors. So these are transcribed and then brought up to the cell surface where they can grab an LDL particle, and that LDL particle can be brought into the cell, and then that is all brought in as a lysosome where the LDL particle is broken down and the constituent cholesterol and triglyceride can be used by the cell for its various cellular functions. But you can imagine, of course, that LDL receptor, hepatocyte or other cell doesn't want that LDL receptor to be immortal. So whenever LDL receptors are transcribed, there is also this molecule called PCSK9 that's transcribed. And PCSK9 is secreted into the bloodstream. And what it does is essentially mark the LDL receptor for destruction. So when PCSK9 binds to the LDL receptor, as you see on this slide, when that complex of LDL receptor, LDL cholesterol molecule, and PCSK9 are brought into the cell, that entire complex, including the LDL receptor, is destroyed, so that LDL receptor can't cycle back up to the cell surface and get more LDL cholesterol out of the bloodstream. So PCSK9 inhibitors are binding antibodies that bind up that PCSK9 in the bloodstream. So when you have these antibodies in the system, there is no PCSK9 available to mark that LDL receptor for destruction. So as you see on this slide, when you have an LDL receptor that comes into the cell with an LDL cholesterol molecule and it's not interacted with PCSK9, it's not marked for destruction, that LDL receptor cycles back up to the cell surface and is available to attach to other LDL particles to bring them into the bloodstream. So when you have a binding antibody to PCSK9, you have more LDL receptors on the surface of hepatocytes, and as such, you have a lower LDL-C in the bloodstream. So that's all well and good in terms of mechanism of action, but how well do these molecules actually work? There are, as I'm sure you're aware, two PCSK9 inhibitors that are currently available in the United States. They are both fully human antibodies, and both of them have been shown to lower LDL cholesterol very significantly when given on top of statins and other medications that lower LDL cholesterol. What you see on this slide is data from phase 3 studies with Alirocumab, given at a dose of 150 milligrams every 2 weeks. And as you see, about a 60% reduction in LDL cholesterol over and above what was seen with statin therapy alone. And importantly, with an incidence of adverse effects very similar to that of placebo. On this slide, you see data from the OSLER program, which looks at Evolocumab, the other PCSK9 inhibitor that's available. Once again, this is a look at some phase 2 and phase 3 data that shows that, once again, about a 60% reduction in LDL-C over and above statin therapy. And once again, with an incidence of adverse effects relatively comparable to placebo. So those studies looked at the effect on LDL cholesterol as the primary endpoint. We now have data available looking at clinical cardiovascular events with PCSK9 inhibitors. We have the FOURIER study that has been published. FOURIER, the methods of the study are shown here on this slide. FOURIER looked at over 27,000 high-risk patients who had established cardiovascular disease, and it wasn't just patients with coronary disease, but also patients who may have had a stroke in the past or may have had peripheral arterial disease. Importantly, these patients were all put on moderate or high-intensity statin therapy, and in some cases also had ezetimibe on board. And then the inclusion criteria was that despite moderate to high-intensity statin therapy, their LDL cholesterol remained greater than 70, or their non-HDL cholesterol remained greater than 100, signifying residual risk based on the data I showed you earlier. And then these patients who met that inclusion criteria were randomized to either receive Evolocumab, 140 milligrams every 2 weeks, or 420 milligrams once a month, or matching placebo, and then they were followed up every 12 weeks, looking at a composite of clinical cardiovascular events. This slide shows the patients who were included in FOURIER. As you can see, nearly 100% of them were on moderate or high-intensity statin. There were about 5% of patients who were on ezetimibe, and baseline LDL-C going into the study was 92 milligrams per deciliter, signifying a significant residual risk based upon their lipid levels. Here you see the changes in LDL cholesterol in the placebo group and in the Evolocumab group, consistent with what the data we saw earlier from the phase 2 and phase 3 studies, about a 60% additional reduction in LDL cholesterol with Evolocumab. So the placebo group, these are patients, remember, on moderate or high-intensity statin alone, achieved an LDL-C right around 90, where patients on moderate to high-intensity statin therapy plus Evolocumab achieved an LDL cholesterol of around 30 to 35 over the course of the study. And here you see the primary endpoint of the study, which was a composite of multiple different clinical cardiovascular events. And once again, within less than 3 years, we see a significant reduction in events, once again proving that we can treat that residual risk even in patients who are on statin therapy, we can lower their risk further by adding another agent, in this case, a PCSK9 inhibitor. Of course, looking at adverse events is very important in a study like this, and there's been particular interest in looking at cognitive function in patients who've achieved these very low LDL levels. And what you see on this slide is a subgroup, pre-specified subgroup of the FOURIER study that looks specifically at cognitive events. So this was done using a variety of neuropsychological tests that were done at baseline and then done after patients were on therapy for quite some time. And as you can see, regardless of the neuropsych tests that were given, no significant difference between those who are on Evolocumab versus those who are on placebo. So based on this data, we have actually seen an update of our guidelines from the ACC. This is a very focused update. This is not a full revision of their guidelines, but an update of their guidelines looking at when we should be thinking about adding non-statin therapy in patients at high atherosclerotic cardiovascular risk. And there are a few different tables that in this document. I want to focus primarily on two of them. The first of these is shown on this slide, which looks at the expert consensus decision pathway on the role of non-statin therapy in patients with clinical atherosclerotic cardiovascular disease and multiple, or at least one comorbidity, which of course is the vast majority of patients who have atherosclerotic cardiovascular disease. So just as in the 2013 guidelines, high-intensity statin therapy is the first-line therapy for these patients. However, if we are not able to achieve either a 50% reduction in LDL cholesterol or perhaps an LDL-C less than 70 or a non-HDL less than 100 in maximally tolerated statin therapy, it may be appropriate to consider add-on therapy. And as you can see on this slide, this document calls for consideration of either ezetimibe or a PCSK9 inhibitor in these patients who do not reach that goal on maximum tolerated statin therapy. In general, ezetimibe is considered to be the preferred choice in patients who need a less than 25% reduction to get to that goal. PCSK9 inhibitors, the preferred alternative in patients who need a greater than 25% reduction to get to that goal. This slide shows the decision pathway for patients with the phenotype of FH. These are patients, primary prevention, who will have an LDL cholesterol of greater than 190. Once again, the 2013 ACC/HA guidelines call for high-intensity statin therapy in this patient population. That remains the cornerstone of therapy. However, if you're not able to achieve a 50% reduction in LDL cholesterol or perhaps an LDL cholesterol less than 100 as a target, once again, ezetimibe or a PCSK9 inhibitor are reasonable to add on to these patients to lower that residual risk. And once again, if you're within about 25% of your goal, ezetimibe would be the preferred choice. If you're greater than 25% away from that goal, a PCSK9 inhibitor would be the preferred choice. And I think these guidelines are very consistent with what we've seen from other organizations, including the National Lipid Association. They recently published recommendations for when to use PCSK9 inhibitors, and in general, they have called for them to be used in patients on maximally tolerated statin therapy who, despite that maximally tolerated statin therapy, have if they have atherosclerotic cardiovascular disease, have an LDL greater than 70 or a non-HDL greater than 100, and then in patients with the FH phenotype, patients who have a residual LDL cholesterol greater than 100 or a non-HDL cholesterol greater than 130 should be considered for PCSK9 inhibitor therapy. So based on this data and these recommendations, we in our clinic have developed some utilization criteria, and others have as well. And I think if you look through the literature, the most appropriate utilization criteria for PCSK9 inhibitors are shown here on this slide. And I think it's very important that this be shared widely with providers. These medications are obviously expensive. We have data to support their use, but I think it's important that we are using them in the right patients. And to determine the right patient, there's really three things that we need to look at. The first is that we're using them in an appropriate disease state, either atherosclerotic cardiovascular disease or FH. And just digging into that a little bit further, just want to remind everyone that established atherosclerotic cardiovascular disease is not just coronary disease, but atherosclerosis in any vascular bed, including patients who have carotid disease, aortic aneurysm, peripheral arterial disease. And then in general, that phenotypic FH patient has a baseline LDL cholesterol greater than 190 with either physical examination findings or a family history of first-degree relatives with premature atherosclerotic cardiovascular disease. Doesn't necessarily need to have positive genetic testing. So the first is the appropriate disease state. Second is that they be on maximally tolerated statin, and that means that not just tried one statin once in their life, but a documented trial of at least 2 statins, one at low or every other day dosing, and keeping a patient on as much statin as they can tolerate, which unfortunately in some patients may be 0, but really finding that patient's maximum tolerated statin dose is very important. And then the third criteria is that they have poorly controlled LDL cholesterol, which I think based upon the papers that are cited here and the guidelines that I shared with you would be a patient with atherosclerotic cardiovascular disease who has an LDL-C greater than 70, or a patient with FH who has an LDL-C greater than 100 despite maximum tolerated statin therapy. And I think once again, really important to be measuring that LDL cholesterol relatively recently. Choosing perhaps ezetimibe in a patient who's close to goal, but in a patient who is more than 25% or more than 30 milligrams per deciliter away from goal, a PCSK9 inhibitor probably becomes the preferred choice. So with this slide, I think I'll conclude my remarks and my portion of the presentation. I will now turn this presentation back over to Dr. Cannon.
Thank you, Dr. Block. I think we all appreciate the information that you've just presented. Moving into and kind of moving towards some of our learning objectives that were further down, talking about the barriers to treatment. One of the things that's important is as we talk about these that I think we level set around managed care. What are some considerations? What is managed care trying to do as they work to manage these patients? I think this slide does a good job breaking it down into 3 buckets for us. There's the clinical, there's the economics, and probably this is a slide I ought to redo. I mean, the patient probably ought to be at the front of this list, not at the back of this list. But I think looking at efficacy and safety of therapies, looking at having appropriate utilization at an appropriate cost, making sure that our patients could be adherent, and also working to make sure that we've reduced the administrative burden to their getting optimal care. So now moving on, what is the role of managed care and what are the contributions that managed care makes to optimal patient care? We know that it includes things like providing accessible and affordable therapies through formulary management. We know it includes aiding physicians in understanding and the implications of available products. And we know that managed care does a good job in assisting and improving and informing those providers that are treating our patients as it relates to guidelines. Looking at a formulary, and I think we're all familiar with formularies. They exist today where they're driven by class. We're all used to seeing tiered copayments, so 3, 4, 5-tiered plans. Many plans now incorporate coinsurance. Step therapy is very common. And as we move into high-priced drugs, they're managed by indication and mainly through prior authorization. So where is it that we really want to go? And I think, for me, I think we want to pay for only for what works. And so we're really moving in that value-based direction. We want to focus on accountable care organizations, and it may not be specifically an ACO, but focusing with those providers that are highly aligned and highly motivated to work in collaboration with a plan and a health system. We want to make sure that we're using targeted therapy, and it'd be great if we could have companion diagnostics so that we are focusing our treatment specifically on that individualized patient. So I think one of the things we will start to see is a migration away from what has been our traditional mode of management to hopefully some more value-based designs within the insurance industry. One of the things that I thought was important and thought would be good to include is the impact of a lipid-lowering disease management clinic. And so really looking at the aggressive management of a patient and what do we get, what do we benefit from that. So within this study, they looked at 2,400 patients. These were secondary prevention patients, and they were randomized to either an aggressive treatment group. That's where they were going to titrate to a maximum dose of 80 milligrams of atorvastatin, or they were going to shoot for a goal of less than 80, or a usual care group where they received treatment just whatever was deemed appropriate by their primary care physician. These patients were followed on average for just over 51 months, and the primary measure was time to first CV event. So looking at the results, and I think what was exciting to me to see was in almost every instance where there was an aggressive management plan in place, you saw better numbers. And so you see better numbers in the primary outcome. You see non-fatal MI. The aggressive management group was 4.3%, and the usual care group 7.7%. It's interesting to me to see that difference, knowing that the usual care group could have had the aggressive treatment, but we're still seeing this difference. You look at those that had an LDL reduction, but more importantly, those that had an LDL reduction less than 100. 72% of those in the aggressive management group and only 40 in that usual care group. So what are the impact of guidelines? Bellows and colleagues took a look at what happened after the 2013 updates to the guidelines. And what they found was that use of non-statin cholesterol drugs dropped from 13% of prescriptions to 6.9%. They saw an increase in the use of high-intensity statins, 6.3 to 23%, and they saw that significantly more patients were adherent to therapy. I think what this shows us is that, as guidelines change, it's an incredible time and opportunity for us to capture that moment and really push the information out to the providers. The 2017 guideline update. So we've recently seen the guidelines for lipid management updated. The new guidelines included a consideration of the randomized controlled trials for PCSK9 inhibitors. There was really no change in the primary prevention group as it related to PCSK9 inhibitors. There were thresholds for consideration of ASCVD risk reduction and % reduction of LDL added. And for those patients with clinical ASCVD, really it's recommended that we're trying to get a greater than 50% reduction from baseline LDL. Okay, moving on from the guidelines. On this slide, you got Brandon Bellows and colleagues that looked at how do they identify statin intolerance. And they did it through two different methods. They convened a multidisciplinary panel. You can see all of the things that the multidisciplinary panel said to look for as far as statin intolerance. And then they had a much simpler list of items that they were looking for as it related to just doing a query against the administrative claims database. I think typically what we've seen in the literature in the real-world setting is that statin intolerance ranges somewhere between 5 and 25%. Some of that, I think, is due to the fact that there's not really a universally accepted definition or real management strategy. But I think in this situation, what they called out were two different ways to identify those patients that are statin intolerant within a managed care population, with 11.3% being statin intolerant based on the definition that was used by the multidisciplinary panel, and 5.4% statin intolerant in that group where they used the administrative claims database. On this slide, I've included the indications for the two products that are currently on the market, Evolocumab and Alirocumab. I think you can see the similarities, although the wording's a little different. They're both indicated in heterozygous familial hypercholesterolemia, and they're both indicated as adjunct to diet and maximally tolerated statin therapy in patients with clinical ASCVD. So a quick clinical update. We've got the FOURIER trial on Evolocumab. It was a trial that looked at 27,000 patients with ASCVD already receiving statins and with an LDL greater than 70. You had a secondary endpoint, which was composite of CV death, MI, and stroke. Median duration of follow-up was about 2.2 years. I think these are amazing numbers, but if you look at 48 weeks, average LDL reduction was about 59% in the Evolocumab treated group, and that's down from a baseline of about 92. What did they see as far as outcomes in some of their primary composite endpoints? They saw a 15% relative risk reduction in that group that included, a composite endpoint for MI, stroke, CV death, revascularization, unstable angina, and hospitalization. They saw a 20% relative risk reduction in their key secondary endpoint. They did not see any differences in adverse events. Did see a few injection site reactions. And then finally, I think, while we've seen a relative reduction in risk, they did not see a statistically significant reduction in CV mortality. On this slide, and just more for reference, I've included all of the medications that can be used for lowering lipids. You've got several products in the statin category that I have not included the brand names just because I think most of the market now is so focused on the generics. But then you can see the costs associated with the two available PCSK9 inhibitors. So looking at the cost effectiveness of the PCSK9 inhibitors, this is some work done by ICER, so the Institute for Clinical and Economic Review. It's an independent, nonprofit research organization that evaluates medical evidence and convenes public panels of stakeholders to interpret and apply that evidence. And so in their report that was done in 2015, what they said was that the PCSK9 inhibitors generated an incremental cost effectiveness ratio that far exceeded thresholds that are normally in that willingness to pay. So willingness to pay being in the $100,000 to $150,000 price range for quality adjusted life year, with the PCSK9 inhibitors at the time coming in at about $300,000. Looking at the 2017 update, what they found, and they looked at the wholesale acquisition cost, and then they looked at the numbers. What would it take? What would the price have to be to achieve the $100,000 mark or the $150,000 mark? And you can see those prices here on this page, where the cost of the product to hit the $100,000 mark would have to be in the $1,700 range, and to hit the $150,000 range in the $2,200. Okay, moving on. Let's look at the use of prior authorization. And on this slide, we have what is a very typical form for the prior authorization of the PCSK9 inhibitors. Within our organization, we sat down with the clinicians in our cardiovascular clinical program and closely worked on defining what is that population that we want to treat and that we believe is most appropriate for using the PCSK9 inhibitors. Our focus was on those patients that have had a clinical event, focusing on those patients that have been titrated up to a maximum level on their statin, but also patients that have been adherent to therapy. I think as we talk about barriers, and what I've done on this slide is really look at a fictional plan, and I think we're going to review a study where I think you can see where some of these things come out. But in this fictional plan, they only had a 7% approval rate for the PCSK9 inhibitors. And when you look at the reasons why, what they said was 40% of the prescribers did not fall into the appropriate specialty. A significant number, almost 80%, were not taken with a maximum statin dose, or they lacked clinical ASCVD. All of these things, I think what it comes down to is documentation. So let's move on. And this final study that we'll review today is some work that was done by Cohen and colleagues. And what they did was they evaluated and discussed with just over 400 healthcare workers the challenges that they face with access and approval within the process for PCSK9 inhibitors. What they found was that initially there's a high initial denial rate, greater than 85%. You see higher approval rates in the familial hypercholesterolemia. So what were the barriers that they saw? One was the insurer's process. The second was the need to provide documentation. And the third was the administrative burden. One of the things that I try and do with our clinicians as we talk about prior authorization is stress for them why the process exists. And I think within our population, it's important to remember that with many of our clients, we're actually paying their claims directly out of their bank account. We're needing to justify for that client that the use of their money was appropriate. And so I think while we want to make sure that we treat all patients appropriately, we also need to make sure that appropriate documentation is in place. And I think what they found within this study done by Cohen was that those providers that provided the documentation that was needed had good approval rates. I think the more information provided at the time of the request, the easier it is for a payer to look at a situation and say, yes, this is an appropriate patient. So in conclusion, cardiovascular disease continues to be a significant area of opportunity for us. As I mentioned early on, it affects 1 in 3 Americans, and it's the leading cause of death. So definitely something we want to focus on. Mortality rates and costs are projected to continue to increase through 2030. The randomized control trials have demonstrated beneficial outcomes as it's related to the PCSK9 inhibitors. The cost effectiveness of PCSK9 inhibitors continues to be a challenge, and I think that's an area that going forward into the future is a significant opportunity for both those on the manufacturing side and the payer side to find those areas of partnership. And then finally, you know, there are opportunities that exist today for us to optimize treatment and to improve outcomes of our patients. And we'll do that through addressing things like treatment adherence, which we know is currently low. Working with our providers, and I think having a good working relationship with those cardiologists within your plan area is critical, so that between the two of you, you can address those barriers to care for your population. This concludes the presentation. Thank you very much for attending this webinar. We will now open up the question and answer session. Good afternoon, and welcome to the Q&A session portion of our program. I'm Eric Cannon, and I'm joined today by Dr. Michael Block. And we're here to take any questions that you may have. So if you have a question, please type it in the question box, and we'll see if we can answer it for you. The first question we have today, Dr. Block, I'm going to direct this at you. And what one of the people in the audience wants to know is if the FDA has reviewed the results of the FOURIER trial, and are there any updates planned to the official prescribing information of Evolocumab?
Well, that's a very timely question because actually just this week the FDA came up with a revised indication for Evolocumab, and the makers of Evolocumab just put it in the prescribing information. So we now have an indication in the package insert for Evolocumab to reduce the risk of MI, stroke, coronary revascularization in adults with established cardiovascular disease. That's in addition to the indications that were already there.
Great. No, thank you. I appreciate that. We've had a second question come in, and I'll try and answer this one. The question is this: when you speak of adherence, please identify how you define it. And the listener wanted to know if it was by the Medicare Part D guidelines or a different or a percent of adherence. And each of the trials varies slightly in how they measure it, but I think by and large, all of the studies are following either medication possession ratio or PDC, or portion of days covered. So portion of days covered being the Medicare Part D guideline. And in the studies, they're looking for 80% adherence as being adherent to therapy. And I think, clearly, we would like to see people take their medication 100% of the time, but I think given how the measurements are done, I think the 80% measure is actually a very good measure. We've had a third question come in, and Dr. Block, I'm interested in this question also. And the listener wants to know how you define statin intolerance, and when people talk about statin intolerance, how are you and your practice approaching that? I think we've seen different approaches across the country and different definitions of statin intolerance, and I think would love to hear your views on that.
Well, it's a really difficult clinical question, and there is going to be a lot of uncertainty about how to diagnose it until or unless we develop a good biomarker. We're really good in clinical medicine when we have a biomarker that we can look at and we can measure and we can say, yep, we know what our diagnosis is. I think first of all, when I talk to clinicians about PCSK9 inhibitors, I remind them that really it's not a discussion of statin intolerance, right? That obviously is something that we talk about in clinical medicine, but when we talk specifically about PCSK9 inhibitors, remember it's maximally tolerated dose of a statin. And I think that's an important part of the conversation, because it does mean that we should be seeking, not just if we're going to use a PCSK9 inhibitor, but in any patient who's at atherosclerotic cardiovascular risk, we should be getting as much statin on board as that patient can tolerate. And statin tolerability certainly does appear dose dependent. So I've sort of ducked the question. I'll come back to that now. How to define statin intolerance is tough. I always say it's very much in the eye of the beholder, and you know it when you see it. There have been a lot of other attempts to define it, and it's been very difficult even in clinical trials to come up with a unified definition. As you saw in my prepared remarks, the National Lipid Association has come up with a scoring system that can be used. Personally, I don't use that scoring system. I do think that the concepts that are in that system can be helpful. Usually statin intolerance is symmetric. Usually it's in the bigger muscles, the bigger, more proximal muscles. Usually it happens relatively soon after starting a statin, but not the first day. Usually it gets better with withdrawal of the medicine, and importantly comes back if you re-challenge. And that withdraw and re-challenge, I think, is the most critical part of the definition. And really to say that somebody is intolerant of any dose of a statin, I think it requires at least 2 and probably 3 different statins to be tried, one of which was tried at very low doses, even doses that are lower than the lowest approved dose in the package insert. That includes every other day dosing, once a week dosing. So it's a vexing clinical problem. We've had trouble even developing clinical trials to look at statin intolerance because of that inability to come up with a unified definition.
No, great, thank you. And I think as people try and define that across the country, one of the things I've told them that has been key for us within our organization was the more we have open dialogue, and I think for us key is making sure that the appropriate patients have access to appropriate therapy, and for us, rather than trying to ultimately define it down, working hand in hand with our cardiologists to say, okay, we're all in agreement about how we're going to approach this and where we're going to use the PCSK9 inhibitors, and I think that's created a lot of trust between the two groups, and I think it's put us in a great situation where we believe we're using PCSK9 inhibitors in the appropriate patients. So
and
thank you
we've
very
had
much for your answer.
Yeah, we've actually had a very similar success. We use a bit of a hub and spokes model in our organization, and one of the things that we've found is that people who've been referred to us for potential initiation of PCSK9 inhibitors, if re-challenged with a statin in appropriate doses, perhaps with appropriate adjunctive therapies, in our experience, we've gotten a large percentage of those actually to tolerate some degree of statin therapy. So trying and trying and trying again, I think, is important and allows us to, as you say, reserve these more expensive medications for those who really need them.
Great, thank you. That concludes the Q&A portion of the program today. Please make sure to complete the post-test and evaluation form that's on the program page that you'll be redirected to in a moment to claim your credit for continuing education. And thank you again for taking the time to join us. We appreciate all our listeners. Thank you.